Hello friends, welcome to my channel. My name is Abhirami and I am here to explain about anticoagulants. So anticoagulants are drugs that reduce the coagulability of the blood. So anticoagulants are classified into oral and parenteral. Oral anticoagulants are taken orally and parenteral anticoagulants are taken through any other route other than the oral. And oral anticoagulants are further classified into four types. These are coumarin derivatives, indadione derivatives, oral direct thrombin inhibitors, and factor 10 inhibitors. So, oral direct thrombin inhibitor example is dabigatran, and indadione derivatives is phenandione, and coumarin derivative example is warfarin, and factor 10 inhibitor example is apixaban, edoxaban, etc. And going to the parenteral classification, parenteral is further divided into direct thrombin inhibitors and indirect thrombin inhibitors. Direct thrombin inhibitors example is hiruridine, lepiridine, etc. Indirect thrombin inhibitors are what we are going to be seeing mainly today. Indirect thrombin inhibitors are further classified into heparin, low molecular weight heparin, heparinoids, and synthetic heparins. So as you can see in the classification table given in the slide, heparinoids examples are heparin sulfate and dextran sulfate, and heparinoids are usually present in the blood. Danaperoid is a heparinoid that is made synthetically, but usually heparin sulfate is present in the plasma. Then synthetic heparin inhibitors are example is fondaparinux, and we'll get back to this later. So then the other two, that is low molecular weight heparins are examples are enoxaparin, reviparin, nadriparin, etc. So next we'll go to history of heparin. So heparin was first identified by a medical student called MacLean in 1916. He first extracted heparin from the liver, so he called it the heparin because it was extracted from liver. And heparin is a glycosaminoglycans, and it is the most strongest acid in the body. Heparin is present in the mast cell of the liver, lungs, and intestinal mucosa. So that's it about the history of heparin. Next we'll move on to the mechanism of action of heparin. So what happens in the body basically is that antithrombin 3 is a protein that is produced from the liver, and antithrombin 3 usually will inactivate factor 10 and factor 2. Factor 2 is nothing but the thrombin. So since factor 10 and factor 2 are inhibited, then coagulation will not happen. So this is the basic mechanism that happens in the body. But then when we give heparin intravenously, heparin will bind to antithrombin 3 and form a heparin antithrombin 3 complex. This complex will inhibit factor 10 and factor 2, and this will also prolong the clotting time. So this process is 1000 times faster than what usually happens in our body. And do you know any other actions of heparin? Other actions of heparin other than being an anticoagulant? So other actions of heparin includes that it activates the enzyme lipoprotein lipase. It activates the enzyme lipoprotein lipase, which clears off the triglycerides in the plasma. So that is one other action of heparin. Now let's move on to the pharmacokinetics of heparin. First, we'll talk about the route of administration. Heparin, as we already know, cannot be given orally. It can only be given parenterally. So which route will we use? We can use either intravenous, subcutaneous route, or we cannot use intramuscular route of injection, because if we use it intramuscularly, it can cause irritation at the site of injection. It can also cause bleeding because it is an anticoagulant. So if it causes bleeding at the site of injection, then it can form a hematoma. So that's why we do not give heparin in intramuscular injections. So we can use intravenous and subcutaneous injections. Heparin given intravenously has a high onset of action. It starts its action immediately, and the action reaches the peak within 5 to 10 minutes. And the person can feel the effects of using heparin within 2 to 4 hours. And how do we monitor the action that the heparin is doing in the body? So we can monitor it using clotting time. So we calculate the clotting time for the patient frequently to see how much the heparin is acting in the body. And one more thing is that we should many drugs cannot be used when the patient is pregnant, because many drugs might cause the placental barrier and injure the fetus. But this is not the case with heparin, because heparin has a high molecular weight and it's a large molecule, so it cannot cross the placental barrier. Since it cannot cross the placental barrier, it will not harm the fetus. So heparin can be used safely during pregnancy. Next, let's go to the adverse reactions of heparin. Heparin can cause bleeding because it's an anticoagulant, so it generally does not allow the blood to clot. So in high doses or when you take the wrong doses, heparin can induce bleeding. Then heparin can also cause osteoporosis and alopecia in many patients, but the reason why it's not known. So why heparin causes osteoporosis is still a mystery, but then it can cause osteoporosis and alopecia in patients who have been using heparin for a long time. Then heparin can also cause many allergic reactions, because heparin is usually extracted from the pig's intestine or from the cow's lung. So heparin, since it's from another animal, when we introduce it into our body, it can cause many allergic reactions. And also heparin, one major complication is heparin induced thrombocytopenia, HIT. So what is heparin induced thrombocytopenia? Platelets produce a factor called platelet factor 4, and heparin can also bind to platelet factor 4. Now this heparin platelet factor 4 complex is seen as foreign to the body. So since it's seen as foreign to the body starts producing antibodies against the heparin platelet 4 complex. Now these antibodies are called antiplatelet antibodies. These antibodies will destroy the platelets and it will lead to a reduced platelet count. This is called thrombocytopenia. And since the patient is having thrombocytopenia, then at many places in the body there will be bleeding, and heparin PF4 complex, platelet factor 4 complex, can induce an immune response. So it can also trigger clotting. So the patient will have both bleeding and clotting. This is a condition called disseminated intravascular coagulation, and it is a very dangerous situation. So that is it about heparin induced thrombocytopenia. And heparin can also cause hypoaldosteronism, because it inhibits the release of aldosterone from the pituitary gland, and this can lead to hyperkalemia. So that is about the adverse reactions of heparin. Now let's talk about the precautions that we have to take when using heparin. So first, we have to keep checking the platelet levels. At any sign of thrombocytopenia, we need to immediately stop the heparin therapy. We should use oral direct thrombin inhibitors instead of heparin, because heparin can lead to heparin induced thrombocytopenia. So keep checking the platelet levels and keep checking the if the patient has any clot in his body, because that can also mean that the patient has heparin induced thrombocytopenia. And if heparin induced thrombocytopenia is confirmed, then stop using heparin and instead use oral direct thrombin inhibitors. Then what is heparin resistance? Heparin resistance is when the patient needs a high dose of heparin for the same illness that they have been having for a long time. This happens because of two theories. The first theory says that the heparin binding proteins in the body will increase. So heparin will bind to those binding proteins in the plasma. This will reduce the amount of heparin that is left for binding with the antithrombin 3. So this will reduce the action of heparin. Or another thing that can also happen is the heparin clearance might increase. If heparin's clearance get increased, then heparin will be excreted in urine. So a large amount of heparin that is injected will be excreted through the urine. So this will also decrease the heparin's action. So this can be the causes of heparin resistance. Then what are the contraindications for heparin usage? So you cannot use heparin in patients with renal dysfunction, because heparin is excreted in urine. If patients with renal dysfunction, the kidney is damaged. So you cannot use heparin there, because heparin will not be excreted properly and it can lead to heparin toxicity in the blood. Also, you cannot use heparin in patients with cirrhosis and bleeding disorders, because heparin already causes anticoagulation. If you use it in patients with bleeding disorders, it will increase the severity. You cannot also not use heparin in patients with thrombocytopenia and bleeding disorders like hemophilia and also neurological disorders. So these are the contraindications for not using heparin. Also, you cannot use heparin in patients with ulcers in the gut. So that is about the contraindication. Next, let's go to the low molecular weight heparin. That is the second part of the indirect thrombin inhibitors. So low molecular weight heparin is much safer, much better than heparin, and low molecular weight heparin has a much less molecular weight than heparin. Examples for low molecular weight heparin is enoxaparin, reviparin, etc. Why is low molecular weight heparin more safer than heparin? Because heparin inhibits both thrombin, that is factor 2, and factor 10, but low molecular weight heparin inhibits only factor 10 and not thrombin. So this will act as an anticoagulant, but it will not affect the clotting time. Risk of heparin induced thrombocytopenia is decreased, and also risk of bleeding is also decreased. So mainly that is about low molecular weight heparin, and now let's compare heparin and low molecular weight heparin. So the standard heparin has a molecular weight of 10,000 to 20,000, but the low molecular weight heparin has only weight of 4,000 to 7,000 Daltons, and the heparin is completely natural, but then the low molecular weight heparin is semi-synthetic, and heparin inhibits thrombin, but low molecular weight does not inhibit thrombin. So the clotting time is prolonged when we use heparin, and clotting time is not prolonged when we use low molecular weight heparin. So low molecular weight heparin has less risk of bleeding disorders, less risk of heparin induced thrombocytopenia, and less risk of osteoporosis. And also low molecular weight heparin has more predictable pharmacokinetics, that is it has better bioavailability than heparin when used in subcutaneous injection. It has a longer time of action. So the frequency of administration of heparin is 4 to 6 hours, but then low molecular weight heparin can be given only once a day since it has a longer T-half. Then where do we use low molecular weight heparin? We use low molecular weight heparin in patients with pulmonary embolism, patients with venous thrombosis, and we also use it in patients with unstable angina, and patients with to maintain the patency of the tubes in dialysis patients. So 4 uses are to use it in unstable angina, to use it in patients to maintain the patency of the dialysis tubes, and then to use it in venous thrombosis and pulmonary embolism. Now let's see about what is a heparin antagonist. So heparin antagonist is protamine sulfate, which is a protein extracted from the sperm of a fish, and protamine sulfate neutralizes heparin. Like 1 mg protamine sulfate given intravenously will neutralize 100 units of heparin. But we do not usually use protamine sulfate. If only a little amount of heparin is overdosed, we stop the dosage of heparin until the patient returns to normal. If mistakenly the patient has taken a huge dose of heparin, then protamine sulfate is given, but it is not usually advised because protamine sulfate itself is a weak anticoagulant. So if not used precautiously, protamine sulfate may itself cause anticoagulation. So and also, how does this protamine sulfate neutralize heparin? Protamine sulfate is a basic compound, and heparin is the acidic compound, so they both interact with each other, and the anticoagulant property is lost. Now let's go to synthetic heparin derivatives, and we have one more topic, that is heparinoids. So synthetic heparin derivatives are made synthetically, and it is a pentasaccharide. Example is fondaparinux, and fondaparinux inhibits the factor 10A, and fondaparinux can be given as a subcutaneous injection of 2.5 mg once a day. It has a rapid onset of action, the T-half of 17 to 21 hours, and it is excreted in urine, and it cannot be used in patients with renal dysfunction. It is used to treat deep vein thrombosis and pulmonary embolism. And one advantage of these synthetic heparins are that they have a low risk of heparin induced thrombocytopenia even than low molecular weight heparins. So they are better than low molecular weight heparins because they have a low risk of HIT. Then the last topic is heparinoids. Heparinoids are heparin-like substances, and most of them are present in our body itself, like heparin sulfate and dextran sulfate. They are present in our tissues, and heparin sulfate will have a thrombolytic activity in when it's traveling through the blood vessels. It has a thrombolytic activity. One heparinoid that we use clinically is danaperoid. Danaperoid is a mix of heparinoids, and it can be used when a patient cannot use heparin. So at a point when a patient cannot use heparin, danaperoids can be used as a replacement for heparin. Danaperoid can be used as a treatment for pulmonary embolism and deep vein thrombosis. So going back to the classification chart, today I have explained about indirect thrombin inhibitors which come under the parenteral route usage in anticoagulants. Thank you. If you have any doubts, you can post it down in the comments. Please like, subscribe and share. Thank you.